Welcome, everybody. Thank you for joining us in our first in a series of webinars by our equity. This one is called Hypocritical Oath, Histories of Medical Malpractice. My name is Jamil Khan, and I will be moderating this conversation. And let me get straight into introducing our wonderful panel. First, we have Prof. Edim Mhlanga, who is an obstetrician gynecologist with 34 years experiences within the public health sector. He is an MPH in maternal and child health from the University of North Carolina, Chapel Hill. He is a fellow of the W.K. Kellogg International Leadership Program. He is registered with the HPCSA and was South Africa's first National Director of Maternal, Child and Women's Health. He championed the Choice on Termination of Pregnancy Act and the Confidential Inquiry into Maternal Deaths. He was co-chair of the National Program of Action for Children and head of obstetrics and gynecology at the Obstetrics and Gynecology Department at UKZN, and also a member of the Biomedical Research Ethics Committee. We also have Dr. Gobani Kambela, who is an award-winning educator and senior lecturer in the Department of Anthropology and Development Studies at the University of Johannesburg. He's a research fellow at the Oxford Research Centre in the Humanities at Oxford University. He is the co-author with Dr. Warren Chalkin of the Anti-Racist Teaching Practices and Learning Strategies workbook. He teaches medical anthropology, anthropological theories and childhoods and youth. He is working on a monograph broadly around what he terms the anthropology of boyhoods, which argues for considered attention to the interior lives of boys. His PhD, passed with no corrections, was an ethnographic exploration of the lives of Amaxhosa men and boys living in a rural and peri-urban context in the Eastern Cape. And last but certainly not least, we have Professor Catherine Burns, who is based at WITS at the Adler Museum of Medical History, where she is an associate professor of medical history, and she teaches and supervises students in the health sciences faculty. She inaugurated the first medical humanities interdisciplinary program in the Southern African region, and she continues to develop this field. She was educated at WITS and then won a Fulbright scholarship to study medical history at Johns Hopkins University. Later, she earned a PhD at Northwestern University in African history. Her research and publication interests focus on women and health history, medical and health history, the history and ethnography of reproduction and sex and ethics in biomedical research. She's writing a biography of a midwife and herbalist from the Eastern Cape, Louisa Mvemve, and has just finished a study of breastfeeding in Southern Africa published by UCL Press, and is completing a jointly written history of South Africa's leading HIV program, the Sinikithemba Center at the McCord Hospital in Durban. Quite a mouthful, lots and lots to talk about. And I would like for us, just as we get started, and I had this conversation with our panelists before we got into the webinar, to start off with contextualizing our panelists in relation to the work. And this work is, of course, medical malpractice, and also as people who are invested in unpacking those histories and those linkages of healthcare and medicine as not only a field of inquiry and also practice that has helped humanity, but also a place that unfortunately has harmed humanity considerably. And I'd like to start off with Dr. Kambela, just to give us a sort of introduction into your relationship to this work. You're muted. Let's unmute you first.
Okay, just want to put on my glasses for my remarks. Thank you so much, Jamil. Thank you, Esihle. Thank you, Dr. Tlaleng, as well as our equity team. for initiating this really important dialogue. So my entry point into this topic is, of course, both personal, having experienced the violence of biomedicine within my own family, but it's also professional. And a lot of my reflections, my opening reflections, will come from my training and my work in both global health and certainly medical anthropology. So in medical anthropology, we have a deep interest in health and illness. And we're really interested in the ways in which both our health and our wellness or illnesses are really shaped by global, historical, as well as political factors. So in medical anthro, we understand health and illness as not only biological, so it's not just what is happening physiologically in your body, but also social factors play an important role in ultimately not only how people fall ill, but also ultimately how they are able to heal. So we're really interested in histories of colonialism, apartheid, slavery, epigenetic trauma, race, gender, class, location, and many, many other factors, because we understand all of these as central to illness and well-being. So for us, medicine is not really outside of the social. And so it's really important to really question biomedicine and the role that it plays. And there's been two central sort of contributions that medical anthropology has played. And really the first one is around questioning the hegemony sort of biomedicine, and assuming that it is the only morally right system. So we've questioned this. And then the second one is really that this idea that biomedicine doesn't cause any harm in society. And again, that's been another area in which we've contributed. So through various concepts such as structural violence, economic violence, pandemicity, and many, many others, we've shown the ways in which biomedicine can actually perpetuate harm and exclude communities and exclude the communities who need medicine the most. As such, we understand medicine as not neutral. Eugene Richardson, in his book, Epidemic Illusions on the Coloniality of Global Health, has written that health practices such as epidemiological modeling, outbreak containment, the ways in which big data is used and abused sometimes in biomedicine, issues of causal inference, and many, many others have been central to perpetuating a range of global inequities. And importantly, as Richardson has shown in his book, that epidemiology from its inception in 1492 has actually been shaped by colonialism, racism, as well as patriarchal systems that keep people from not being able to meet, that keep people from being able to live lives of optimal well-being. As such, it's become really important for us that we turn our attention to what some medical anthropologists have called the dark side to medicine and attend to the ways in which biomedicine harms. And through this concept, there's a concept of clinical astrogenesis which was made popular by Ivan Illich. It really challenges us to really look at the ways in which patients are injured in the clinical setting due to not just what is often thought of as innocent mistakes, but through ineffective, erroneous, and unsafe treatments. It demands that rather than we see harm in the biomedical context as unintentional or as accidental, but that we interrogate the ways in which it emerges from deliberate, direct, and systematic medical acts and processes and encounters. As such, we must not only attend to the spectacular. So a lot of the times when we talk about medical negligence, particularly in the South African context, we focus on the big cases. But we've sort of challenged this to really argue that we also need to attend to the everyday processes, issues of bureaucracy, and the ways in which, for instance, issues of undersourcing of public health infrastructures, as well as the over-medicalization in health settings, keep people from being able to heal. So before I close, because I know I only have about 5 minutes, when I was preparing for this presentation, I thought about one of my students. In 2019, one of my students came to me in the office, and we were dealing with these issues of structural violence in a course I teach on Southern African perspectives on health and illness. And she was sharing with me a story of her own family, and that she's actually at school as a form of working towards justice for her family, because half of her family is disabled. And part of that was because of the negligence of the public health system. And so it raises questions around how do people really engage public health if it's been a space of so much turmoil for so many people. There's a line, I forgot the author, but who writes that, you know, how does one seek care in a space which for some people it carries memories of torture. And so I think one of my challenges in thinking about biomedical negligence is really to expand the ways in which we think about harm. A lot of the time we focus on physiological harm, but also we need to attend also to the forms of damage that it does to families, as has happened with my students. So engaging issues of the mental health effects, issues of spiritual death, social death, and many others. But I think I'll stop there so that my colleagues also have a chance to share. Thank you.
Thank you for that. And I absolutely love that you framed your entry point into the conversation in that way, because in some of my sort of research for the discussion today, I have come across a couple of contributions that you've published around, you know, biomedical intervention not being the only option and having to look at how that came about. But we'll get into that later. I would like to now invite Prof. Catherine Burns to give us also just a little short introduction about her relationship to the topic and the work, and just to give us a little bit of a framing for what's to come.
Thank you so much. I echo the comments of my colleague Gobani from UJ. We were actually involved in some co-teaching last year, and it was wonderful to have anthropology and history perspectives in an online course that was, you know, evolving in the beginning of a pandemic. And of course, it's also a great honor to be here with you and our human rights colleagues in our equity, and also with Eddie, who will be speaking just now. The perspective that I would like to bring obviously takes us back a little bit further into the past than ethnographic and anthropological work, which is crucial in unpacking the complexity of the present. And one of the ways that I got into this topic was a strong interest in colonial era, pre-colonial, and then in the segregation and apartheid era history of South Africa's journey towards medicine and health institutions and how they formed, the sharing of medical knowledge across cultures, the hierarchies that formed within biomedicine, in those days often called Western medicine, but the way in which it drew upon a very vast cornucopia of medical knowledge from Southeast Asia, from the African continent, from further north, and created out of itself over time a particular set of paradigms, excluding some and maintaining others, but also the history that everyone in this webinar will also be aware of the continuous parallel that happens in all of our lives between what we might call the practice of clinical medicine or biomedicine, and then the healing arts of our own families, the resources that we draw upon, which my colleague has already addressed, that come from affect, that come from even such things as cooking and cuisine, that come from caring cultures. And we are also all aware that whether we're inside of the family or whether we're inside of the hospital, various kinds of forms of power can bring themselves to bear when we're very vulnerable, when our bodies are suffering, and when we are facing illness and death. All of us have faced and will face illness and death. All of us have celebrated the return to vitality and health, and all of us have been born. And this journey is common to all humanity. That we can also, all of us, empathize with and understand that there are certain domains of knowledge in our society, take South Africa today, that we hold often in really high regard, and we expect a very high standard to be met by people who are practitioners of and who are rewarded by society for their role in positions of power and authority in health and medicine. That could be people in a medical school, that could be people running a hospital. And it's there that we have this really complex tangle, don't we, of expectations as people. Many of us know, doctors and nurses, that we honestly have experienced the greatest kind of care from. People who've put years of education and learning, and an enormous amount of self-sacrifice into achieving and accomplishing a skill that we've drawn on as people. But many of us are also aware of doctors and nurses and other healthcare practitioners who have not cooperated with ourselves in the journey towards health, who've been hierarchical, who've brought their own prejudices even unwittingly to bear, and who've drawn upon or retreated into top-down, institutional, and often objectifying responses, possibly sometimes because of their own vulnerability or their own unexamined prejudices. And what historians have really, I think, offered, especially historians of the changing forms of ideas and practice and social historians, is we offer into the world of the Hippocratic Oath and of the question of hypocrisy and tension in medicine, the insight that if we look back over time, medicine is not something that comes into the 21st century without a huge set of archaeological strata beneath it. It is not innocent of, and how could it be, the issues of power and prejudice of the world we live in. And medicine has to have the courage, and we have to be in that journey with it, to be self-reflexive. South Africa is such an interesting place, Jamal. We have in our country a kind of compressed set of some of the most extreme forms of self-sacrifice and self-reflection on behalf of medical practitioners, one of whom is in our conversation, as far as I'm concerned, who's coming up next. But we also have examples in our country of medicine being used and medical authority and medical power to divide people, the so-called sanitation syndrome, which became a basis of racial division, stigmatizing certain kinds of bodies, certain kinds of illnesses, tuberculosis, silicosis, HIV/AIDS, and other pandemics, authoritarianism in telling people that they didn't have self-knowledge that was worthwhile in the journey of their own health. Huge amounts of gender division. It's taken an incredibly long time for women to have equality with men, and they're still struggling, even inside of the medical academy. And if we look at the division between nurses and doctors, this is still apparent. And then very painfully in our own history, many, many instances, even in the 20th and 21st century, right up to the Life Esidimeni scandal that we tragically lived through a few years ago, right into our pandemic today, where health professionals who have actually sworn an oath to protect people in the country and to protect our infrastructure are found to be less than what they committed to. So we have all of that rich history in our own country. And I think that's what historians do bring to the table, together with medical practitioners and people who work focus mainly on the present, such as my colleague Kobani from UJ. Thank you.
Thank you so much. And I think if we were to have the scope to explore each and every one of our panelists' interests and expertise, this webinar would probably be about 6 hours long. But thank you so much for that, Prof. Burns. Next, I would like to invite Prof. Eddie to come on and situate himself within the context of this work. And Prof, I know that this is probably something that you have related hundreds of times, and it never ceases to give me goosebumps.
Thank you very much, and I feel honored to be on this platform. I also am owed to this opportunity, especially following on the very good presentation given by my colleagues on the platform. I'm from a very rural area, and my first impression of the call to be a doctor was because my brother was knocked down by a car, and he spent quite a long time in hospital, 9 months in all. But for 2 weeks, he was unconscious in a hospital. Then when I saw what the doctors and the nurses did, I thought, well, I would also want to make a difference in people's lives. And that brother is still alive today. Unfortunately, just about a month ago, exactly, I lost my sister, and in 2018, I lost my brother. Again, probably this time from not enough attention being taken in the treatment of those two. But let me get on to the question of how I became an obstetrician gynecologist. I was very much afraid of women, having grown up in a very conservative Christian environment. The hospital that I worked in from the age of 10 was very conservative. So you could not even be allowed to speak to a woman who was not your blood relative. So I went right through medical school, really keeping my distance from women. But when I got to the rural hospital where I ultimately worked, I realized that women and children were dying because of inadequate skills amongst the colleagues who came in with other skills because they were specialists from America. So when they were physicians, so they were internal medicine, but they knew nothing about obstetrics and gynae or even pediatrics. So that's how I got in. So reluctantly, apprehensively, I went in to start dealing with these women who would obviously likely to fall into temptation, having to examine all these, naked women and so on. But that was my calling, and I'm glad that I listened to that call. So I see myself really being privileged to work with and for women, and most of my bosses have been women. So yeah, and my role, I've seen my role basically to treat always, but to restore sometimes, then to listen always, and to comfort always. And during both my student days as well as a registrar, part of my job has been to go to the wards and also offer comfort and pray with patients and so on. So it was not only just the medical side of things, but also on the spiritual side. So from the days of apartheid, when the challenges of skin color poverty, illiteracy, and cultural and traditional practices, people often not understanding this, often the religious zeal, the missionary hospitals justifying the disregard for human rights, up to these days when materialism is very up there, your money, and sometimes being in the wrong group because of your gender, because of illiteracy, particularly health literacy, we face challenges. So in our institutions and so on, we have seen right from those days how malpractices often come in, and when if doctors make a mistake, then there is silence about that. But if the patient has not adhered to what has been the instruction of the doctor, the heavens will fall down because they have disobeyed this holy or supreme instructions from above. So I've been fortunate also to go through with the World Health Organizations. I've been part in the Gender and Health Advisory Committee. I've been fortunate to be in the Department of Health right from 1995, when we set the framework and the foundation for human rights in medicine, and also working with the Health Professions Council. I think I'll stop there. Otherwise, the sun will set whilst I'm still talking. But the challenges we have of people with disabilities, of people of various genders, women and children, and the issues of informed consent, people knowing exactly what's happening. And indeed, this COVID-19 has shown us, even amongst health workers, how many of those health workers actually knew that the immunization that they were getting was actually research. It was not treatment. And but people haven't, because of the lack of information, people have then put themselves forward. Let me stop there. Other questions will come later on, but thanks very much. Thanks for having me. Thank you.
You're very welcome. Before I get into having a more in-depth conversation with our panelists, I just want to remind everybody watching, if you would like to tweet about this or share it on social media, please do use the hashtag #OurEquity and get those conversations going there as well. And of course, if you have any questions, we will try our best to field them in the Q&A section. So if as and when they pop up, please do pose those questions. There will be 30 minutes towards the end where we can really pose those questions to our panelists. So I wanted to start with Prof. Burns, and also while I was sort of reading through some of the work that you've done, there was a particular article, and it was published a while ago in 2004 already, but there was an article that you wrote called "Controlling Birth, Johannesburg, 1920 to 1960," and there was such interesting sort of insights that came out of that research that I thought I'd like maybe to use as a pivot for us to facilitate the conversation with you. And I'm sure there's been a lot since the publishing of that article, you know, that has supplemented and augmented the information generated there, which of course you would be able to fill in for us. But I wanted to put forward three points out of that article that really stood out to me for your consideration in responding, and that was, the one is the evidence of fertility control in African societies dating back many decades before even the idea that contraception was introduced in from the 1930s onwards, and the fact that people practiced sort of control over their fertility and also had their own ways of contraception. That is a complete contradiction to this idea that global South communities, and particularly South African communities, just had no idea about this, and of course needed help in understanding, you know, contraception and control over such things. And then there was another thing that jumped out to me in the article, and this was the idea of suitable and unsuitable women in relation to contraception as a function of both race and class. And, you know, I mean, the idea itself to term not only women but people as suitable and unsuitable for anything relating to health is a quite a interesting one, in that there's a violence attached to that kind of understanding of people, which segues into the third idea of, you know, the real practice of eugenics and ill-informed and ill-gotten consent, which is something that Prof. Eddie just touched on now, in relation to contraception, fertility, and in many ways, actually healthcare in general, right? So I'd like for you to sort of, in the context of that article, but then also just in the work that's been done since then, sort of give us a couple of insights relating to those points, if you don't mind.
Thank you so much. Yes, I think the first of your three-pronged overview that I'll pick up on is the question of what and how were the methods that people in the world and in Southern Africa used to control and work with their fertility and their sexual reproductive power before the modern era. And I actually wrote another paper about this in a journal called Agenda, which is called Sex Lessons from the Past. And it looks at a range of human sexual expressions in global historical knowledge and in Southern Africa which often have been passed down through cultural forms of knowledge, such as statues, dances, music. This is where I'm overlapping a lot with the knowledge of people like Kobani, but also the gynecological and obstetric knowledge of Dr. and Professor Eddy, because we all know that in our own lives, in our own awakening as sexual beings, and in our own journey of sexual orientation, sexual practices, that it's not only some form of biological imperative, which is no doubt there too in the reproduction of ourselves as mammals and creatures on the earth. There are religious, cultural, social, familial, and many, many other factors that come into play in our sexual orientation and our fecundity. Our desire for sexual enjoyment and pleasure is not exactly the same as our fertility. For example, if I'm in a lesbian relationship, or if I'm chaste and I never have a sexual relationship with another person, I take a vow of chastity, I am still a sexual person. My orientation is different depending on the life strategy I choose, the community I live in, whether I've got physical disabilities and challenges, whether there are pressures on my community, whether high fertility is valued and given a huge amount of support by the community, or whether I'm living in a time of famine, my community is on the move, I am myself a migrant labor, I'm working as a slave, I'm working as a farmer, I'm an aristocrat, I have people to help me, I have no one to help me with children, the resources of protein in the community, so many factors in the thousands of years of human history that we have recorded shape both our fertility and our fecundity. And so it is no surprise at all that whether it was Ireland in 1840, where my great-great-grandmother came from, or whether it was the community that probably Dr. Gombela's family came from, let's say in the 1830s, in both sets of cases, modern contraception did not exist. This is only a phenomenon of the 20th century. And all communities, whether they were people who were practicing a particular local religion, or whether they were part of a global, for example, faith community, all human beings have always given thought and attention to fertility and fecundity. And so it's absolutely ludicrous to suggest that fertility control or preventing conception is sort of the invention of some mad geniuses in 1930. In fact, what promotes the development of hormonal and new forms of barrier contraception in the 20th century is a complex mixture of extremely powerful eugenicist views about controlling the poor, first in Europe, and this also is the undeserving people, such as people who were considered to be uncivilized inside of European communities. And this often was tinged with racist and other pejorative thinking, or an effort to control the poor in the global south or places like South Africa. But I have to immediately add something that's so fascinating and tricky, and that is that a lot of people who funded and who pushed contraceptive knowledge and development in the 1930s and 40s were also people who were opposed to eugenics. And this included a whole lot of proto-feminists, people like Margaret Sanger, and people who were involved in global movements that were also for peace and anti-colonialism. Extraordinary complex mixture of people. Just like today, if we look around us, people that are trying to make sure that women can have more control over their bodies, that people can make more informed decisions about their sexual orientation, that we can support a range of different approaches towards personhood in life. We can have a lot of very progressive human rights facing people saying we have to have choices. We have to put the technologies that we have available out there for everyone to use. But we also know that in our communities right now, there are people who are wishing that they could use certain kinds of scientific technologies to close down or shut off options to other people, who see carceral or punitive forms of power in, for example, controlling people's fertility and sexuality. So since we can see that tension in our world now, it's not a surprise that that tension existed in our world in times when there were far fewer human rights and where the conception of equity and dignity was not widespread. So let me come to the second and third prong more quickly than the first one. The second prong I find really fascinating. Who are suitable and who are unsuitable women and men? and who gets targeted and who does not get targeted for different interventions and policies. Just let's take something that Globadi knows a lot about. In South Africa, when there was a decision that to medically circumcise young men before they were sexually active would be an added aspect of a prophylactic campaign against later HIV infection, on the surface of it, that could be potentially an interesting idea. Let's look at the evidence. Let's see how young men think about circumcision. Let's look at the past and how people practice circumcision. But of course, in reality, as we all know, circumcision of a medical sort in an HIV/AIDS program was targeted at only one kind of man's body in the country, mainly Black men living in urban and peri-urban areas. No white men were targeted, no men of mixed background, no wealthy men, no men who had access to resources to sort of escape that gaze. So there's one story. Let's talk about a targeting of women. A couple of years ago, our current Minister of Health, who was then the Premier of KZN, and Dr. Sibongiseni Max Flomo, who was then the MEC for Health for KZN, they instituted a program in which they tied the right of a woman to go and have a scholarship to go to university in South Africa or abroad, in this case to Cuba, to whether or not they signed up to an implant, which was a hormonal contraceptive. Now, right through the last days of the apartheid era, as I was becoming an activist and a researcher, I was absolutely outraged, and I was part of a community of activists fighting for women's health with people like Makosazana Kaba, Barbara Klugman, Sharon Fon, the list goes on, demanding that the government should not be allowed to target Black urban women with Depo-Provera without their consent, or to push certain kinds of fertility or contraception technologies on different communities. And we were rightly outraged about it. We went all the way to the UN, to the Beijing conference to talk about this. And there were huge amounts of people who were activists in the communities of South Africa organized around this issue. One of them was Emma Mashinini, a trade unionist, and there were many others. But how horrifying was it to discover, some 20 years after the end of apartheid, that people of high standing, whose own mothers and sisters and wives had gone through this when they were younger, actually implementing a policy that tied a woman's right to something to control over her fertility, when men were not targeted in the same student group, and nor were women with different colored skins or in different parts of the country. I was absolutely outraged. I wrote letters about this, I wrote in the paper, but far fewer people spoke out against this than had spoken out against this 15 or 20 years before. What do I learn from this? I learned from this that stigmatizing people and using medical technology and other forms of power against people instead of for people is not the gift of only one kind of authoritarian regime. I learned from this that people always have to participate in their own health rights. People have responsibilities. They have to be active citizens in their own health. We must never give power over to one or another authority. That means that we as ordinary people also have to be very responsible and informed about our health. And we can never rely on one kind of paternal figure to decide issues for us. But on the other hand, it also makes us very alive to the fact that in history, over and over, women in particular, but also younger men's bodies, are often considered to be dispensable by people in authority. Even when the people in authority are legitimately elected, this does not stop them from being accountable to basic human rights issues. So that's why I feel that issues from the past have not been put to bed. They come right into the present now. And these gender divisions and these divisions, for example, around sexual orientation, the way that particular people get targeted, continue to haunt the imagination of our contemporary lawmakers, including many highly placed medical professionals in our country. And we all have to be alive to this.
Thank you so much, Prof. Burns. And I just wanted to say, that particular angle around this topic is important for me, because a lot of what you will find when you try and search, like what does medical malpractice in terms of history look like? It often has a link to violating people's bodily autonomy, controlling people's sexuality, controlling their sexual reproductive health. That has been a big part of how our medicine as a field has performed such crimes. Basically, it's crimes against humanity. And I think when talking about it, a topic like this, it's always important to sort of ground it in that issue, particularly because I think it gives people a way to see medical malpractice as linked to so many other kinds of prejudice and oppression. And so with that, I want to come to you, Dr. Kambela, and just the work that you've done around illuminating histories of mistrust, right? What Prof. Burns was talking about has a direct sort of link to what we even see now during this pandemic, right? Where people are hesitant to take a vaccine, where people are, distrustful of biomedical interventions for a public health crisis. And it comes out of, and particularly in the global South, Africa, and in South Africa, we have our own very specific history of how government forces and sort of legislators have committed crimes through using, the medical field. And then that has obviously generated a level of distrust amongst people, especially for Western biomedical interventions. And you do very interesting work with so illuminating the history of that distrust, and then also offering another perspective on how, when thinking about interventions for people, one must also consider the systems and structures of intervention and healing that exist in people's cultures and that they do trust, and how that can also be used as a way in which to promote and achieve wellness amongst people. So would you like to expand on that a little bit?
Sure. Thank you so much, Jamil. I think you raised such an interesting point. So one of my students who just graduated actually a few months ago did his master's on vaccine hesitancy in South Africa. And it was interesting because he started the research in 2018, so long before these conversations about COVID and so on. And one of the concepts that he works with, Gekana is his surname, Lishonolo Gekan, is this notion around what is an unsanitary citizen, right? And I think we can't take out issues around citizenship when we think about the kinds of experiences that people have with the biomedical system, particularly in South Africa. And you correctly note, for instance, that there is a valid skepticism around the limit around how far people trust the biomedical system, and that is of course linked to the kinds of ways in which particularly Black people's bodies were experimented on under apartheid. One of your colleagues, Esihle Lupindo, in his dissertation has a beautiful chapter actually around the crimes, for instance, that the medical crimes that the apartheid government instituted, particularly on queer persons under apartheid across the racial groups. So I do think, and I think the article that you're referring to is the NIHS one, and I think there's a lot of conversation that we need to have around the ways we think about who is sanitary and who is not, as well as the role that our history and still ongoing, actually, people's experiences with the biomedical system have restricted the trust between them. So, and then the other issue you talk about is this issue of medical pluralism, which is really that we don't really have one hegemonic system in South Africa. People consult traditional healing churches, of course, biomedical system, various forms of homeopathic healing. And it's always an interesting conversation because, I mean, as Professor Burns has already noted, that, you know, the biomedical system is relatively new in the African context when you think about it historically. So people have always had various other avenues in which they heal, in which they make sense of their illness and so on. But it's always interesting, and again, this really links back to this idea of biomedical hegemony, which is whenever someone makes a mistake in a clinical setting, it's seen as genuinely like that they are skilled, they've made a mistake. But as soon as a traditional healer does something wrong, and then it's used to represent the whole system. I mean, I don't have one particular view on this. I think all systems have their own complications, and it doesn't necessarily mean that, you know, for instance, traditional healing is exempt as well from critical scrutiny. But I think it's always telling, and I think it's been so evident in this COVID era, the ways in which only one particular form of healing has been favored. And there's a young woman, who's doing research now on traditional healing and COVID-19. So I'm really interested to see what will emerge there around, you know, the ways we challenge biomedical systems. But I'll stop there.
All right, thank you so much. Yeah, I think what's important about what you've said, I mean, there are many important things, but one important thing about what you've said is how when not considering that there are like multiple systems and forms and ways of dealing with illness, and then also sort of healing, that creating a monopoly on intervention or healing creates this kind of like industrial complex that people are obliged to abide by. There are no ways in which one can except for legal avenues, which Prof. Burns has also alluded to, the ways in which those can be abused. But one has no recourse, there's no negotiation, there's no sort of discussion about, or actually the word is consultation, you know, consultation between a practitioner and a patient. And that lack of consultation, even though ironically, doctors often refer to consultation as what they do, but what that lack of consultation invites again is this human rights abuses, right? And the fact that we cannot divorce the medical field from its obligation to enforce and protect human rights. And I suppose that history of that disconnect between the two has been largely the inspiration for this discussion. So thank you very much for that. I want to direct us towards Prof. Eddie now, as somebody. So we've heard a lot about sort of research. We've heard, you know, the way our panelists have been thinking about things, and then, you know, sort of relating experiences of people through that research. But we are very fortunate to have Prof. Eddie with us, who is somebody who has been in that actual position, you know, of having to be a healthcare provider and seeing the inequities and injustices in that field. And so I think it would be remiss of me not to bring out sort of more of a practical contribution that somebody like Prof. Eddie can give us. So I want to ask you, Prof. Eddie, what have you learned in 34 years of practice about what healthcare needs? Those, and in particular, so your field is obstetrics and gynecology. So you work with people who have uteruses, and I want to foreground the importance of that kind of healthcare in this context. So what have you learned about what healthcare needs those with uteruses have what healthcare needs those people have, and how systems need to be reformed to enable such healthcare.
Thank you very much, Jamila, and thanks very much to Dr. Kambela and Prof. Benz. It just raises a lot of goosebumps to actually realize the enormity of what is actually happening. Not only will I talk about the importance of those with uteruses, but with vaginas and so on, because that whole field below the umbilicus and above the knees, it's almost like an open field for people to experiment in and decide on, particularly males or relatives of males having control over the woman. I think one of the things that you refer to is the whole issue about who decides on fertility and how is that fertility curtailed. And it brings us back to the issue of what is informed consent, and do we divulge all the information, or do we only divulge the information that we think is important for the patient to give a positive response to our suggestion? We certainly do not tell them about the complications of this intervention. I've lost a sister following tubal ligation. She had just given birth even before she took the child home. She was done a tubal ligation, and she died in the recovery room of a theater in this country. So whilst doctors will often say, "Oh, this is a very small thing to do," and often say, "No, you have enough children because we think enough children is just maybe just 2 children or 2 males or a male or a female." We make that decision and then coerce, or rather try to influence the women to do that. And it is malpractice. It is, and we have seen this happening right from the days of apartheid, where control of the Black population was the primary aim of the family planning program. Actually, if you needed anything, almost like today, where if you need anything, you have to code HIV and AIDS, then you get funding. In those days, if you needed anything, you just have to put in the family planning aspect to it, and then you'd get those resources. Some of us were trained to do laparoscopy and things like that, because we said we're working in family planning, and there was no limit to what you could get. So the issue of the importance of the womb to a person, and we often think of it as a physical thing, but it's also a spiritual thing. It's also a psychological important organ in the body. So we have seen many people where it said, well, you have had a cesarean section, you have had 2 previous cesarean sections, the 3rd one, make sure, because that's going to be the last one, and we're going to close your tubes. And sometimes even without telling the patient, they said, no, you have had enough operations, now your womb is in tatters, and therefore we're going to close that womb without giving anyone any information. So the issue of informed consent, there's more and more of that now coming on to say, let the person, in a language that they can understand, but at a level that they can comprehend, so that they can then make that decision. Fortunately, it's in 2000, I think it's 2004, when now the act came through to say that only a woman can make that decision about her fertility. And it's not the doctor, it's not the husband. In the past, we used to require the husband's signature Of course, what used to happen, many of the women were very, as women are always clever, because they are the ones who brought us up. If they were not clever, then we probably would not be clever as maids. They would just go outside the hospital and get some men to sign where husband is supposed to sign, turn around, come back and say, the husband has signed, and then we would of course just agree and then go on and do the sterilization. But the importance of saying what are the complications, I think that's one. The second issue I wanted to mention is that there are other methods of if you decide you're not going to have children, not to have children. We in our family, we've never used any of these modern contraceptives, right up to now. No, we haven't, because of the complications that may arise, your deep vein thrombosis, the change in moods, the increased susceptibility to hypertension and various other things. But we don't say that to the patient. So we are guilty of that malpractice. Sometimes we see somebody with a disability and we say, what are you doing? You can't even look after the 2-3 children that you have. Therefore, we'll need to sterilize you. And many have been sterilized. HIV, people have said to them, look, this is the kind of situation that you are in, and therefore you have to be sterilized. I think there's a case currently of this forced sterilization, and people are going this way, that way, trying to justify why they did what they did. Some of those sterilizations may have been justified, but they were done without the knowledge or the consent of the woman, even in a situation where it might be life-threatening, but you still are required that if it is not life-threatening to take up that womb, then you cannot sterilize that person for fear of the future. But if then you think this is life-threatening, then to go on and to say, yes, I will do it. However, immediately thereafter, you then explain the situation to the patient. So that is the thing that we have to look at. Now, LGBTI communities, what is our role? Today, hardly anyone teaches medical students about the LGBTI community. In the Department of Health, there is not a program, not a single program that is fashioned so that it caters for the LGBTI community. So it's like it's forgotten. It's not important. I can safely say that when I was at the National Department of Health, I was the only one who actually ever went to a transgender LGBTQI workshop. No one was prepared to go there. No one was prepared to start looking at those issues. Up to this very day, nothing is happening. We come to the Choice on the Termination of Pregnancy Act. Okay. Currently, how many hospitals are providing termination of pregnancy services? Not more than 40 in the whole country. Not more than 40. And yet women are raped and they don't want the pregnancies. But people saying that we are serving everyone, human rights. But are women not humans? Do not they have rights? Many times we say, my religion, my tradition does not allow me. But when one becomes a doctor or a health professional, you undertake to provide care for everyone, irrespective of their beliefs, their religion, their gender, their color. So we still have to work on those, because although it's a new era, we still have the mindset, that colonial mindset, that apartheid mindset that says, no, some people are less of human beings than others. So I see that as a refusal to care. And therefore the Hippocratic Oath that we took, it's hypocritical. We're hypocritical, really, because we do not really adhere to that which we committed ourselves to, despite the fact that those very same patients are the patients who are paying for our salaries. So they pay for us, but we refuse to provide a service. I'm not so sure what we call them. So one of the things that I believe we need to do is really to be advocates for the patient. And then lastly, maybe I just touch on two issues. I think there's been tenofovir gel. I want to raise it now. Tenofovir gel at one time was promoted as the answer to HIV. And I think in one of the HIV conferences in Vienna, Austria, it was presented as such. But that research was done despite an ethics committee saying, no, you can't do this research because available evidence shows that those people who use it actually may be more prone to acquiring HIV. But because of political economy of health, where people decide what happens, that was done. And then later on, when other countries started experimenting with it, only to find that more people were turning HIV positive by using that gel, then it was quietened down. We don't know what happened. The second one is the issue about the implanon. Now, the implant for contraception has got a long history. It was first used on African Americans in the US and things like that, because they felt that these people are not intelligent enough. But it caused horrendous problems when people were trying to remove them. And then it came to South Africa. And 1995, 96, we said no implant in South Africa. But then a few years later, it then came up and said, we're going to put implanons in women. Now, this is not just doctors putting it. Now, in some province, we even had nurse assistants inserting these implanons into the arms. But it became quiet because certain individuals were promoting this. We had to stop it in Mpumalanga. In Mpumalanga, we said we are no longer inserting implanons because of the complications. However, I think now it is coming in again through the back door. Again, it is being promoted. Whereas a woman, once she has that, she cannot have it taken out except to find a doctor who then takes it out. And some women have actually asked their colleagues under no anesthetic to use nail clippers to get these things out because of the complications of bleeding and headaches. So these are some of the issues that we still have to grapple with and we have to contend with. So I'll stop there. Sorry, I do get a bit excited, but we need some passion in addressing some of these issues. Thanks very much.
Thank you, Prof. Eddie, and no need to apologize. That is exactly what we needed. You know, and listening now, having listened to all of the panelists speak, you know, the thought that comes to mind for me is that the purpose of this discussion, though not necessarily focused on the execution of accountability for one particular person or even a group of people, the conversation is about accountability in biomedical practice, and that accountability is about ensuring justice, and justice in medicine is racial justice, it is gender justice, it is justice for people with disabilities, it is justice for queer people, it's justice for trans people. So these issues are never ever, like Audre Lorde said, there are no single access issues. There are no single struggles. You know, everything is interlinked. Everything comes down to the fullness and the wholeness of what human beings are made up of. And so I just want to say thank you to our panelists for the generosity with which you have participated. And I've seen that in the chat section. You know, Prof. Burns has already shared resources and answered people. This is really, really so wonderful. I want to invite us to ask questions. I have noted that there are a few, and I'll start off with that. And while we are having that discussion, if anything comes to mind, please do just pop it into the question section or in the chat. I see some of us have used the chat. And also just to remind everybody still watching that if you want to tweet about this or talk about it on social media, please do use the hashtag #OurEquity. I want to go, there was a question that I saw that Prof. Burns answered in text, and I want to read that into action and also pose it to the other panelists. And the question is by Daniel Kiwi. I hope I pronounced that correctly. The question is to the panelists, but extending what Prof. Burns has said, I have a question relating to law and malpractice. Fons warns that there is too much legalism in medicine and too big a worry to be legally liable and not enough to practice medicine. Is the law, in a way, a barrier to open and honest conversations about mistakes? And I'd just quickly like to read out Prof. Burns' response before posing that to our other panelists. Prof. Burns said, Daniel, there are many barriers to good practice, and linking legal struggles to financial gain, the origin of which may have had good motives, reasons behind it, has added a huge burden without evidence that practice has improved. Prof. Eddie Mhlanga's efforts to get a confidential, rigorous peer review process going in childbirth settings was a massive breakthrough with SA Medicine. The aim was to draw out rigor and standing and sanctions and corrections from within the space to constantly improve, drawing in community elected people in the review practice. Thanks, Prof. Byrne, for that response. Dr. Tambela, do you have any thoughts on whether there is too much legalism in medicine?
Yes and no. This is really not an area of my expertise at all, so the law but I mean, I can only generalize, and I think the key word that you used, Jamil, was accountability. From what I've observed, and certainly the anthropological archive, we know that there's often, we know that in South Africa, the legal system is very class-based, right? So usually the people who are able to access legal recourse or forms of accountability in that way are often people with the kinds of financial resources to take these cases to the High Court or to the Constitutional Court if they are lucky. So we know that there is a class barrier around how people can actually report, particularly in cases of medical negligence. That's why my student is going to school, so that she can have money at some point to be able to get some kind of justice for what the medical system did to her family. So I can really only comment in a general sense like that, from what I've observed, that unless, that's why I spoke a little bit earlier on about issues of economic violence and issues of structural violence, because we often know that to actually get through bureaucracy in South Africa, you do need quite a bit of class, economic class access. And my experience is that certainly in my family, my students, and so many, there's so many narratives in the public domain that we know that people are often not able to access the law in that way. But I think Prof. Mhlanga can have more substantial comments as a person who's been practicing.
Thanks very much. Yeah, I think you're right. It's not an easy question to answer. Indeed, the access to the legal system is a major thing. So what we do as a medical profession often is that we keep people in the dark about their rights. Now, and anyone who needs to then question has to get to a lawyer, and that access is not easy. Yes and no, that the increased litigation does lead to people practicing sort of what you call defensive medicine, okay? But defensive medicine does not necessarily say, therefore, you need to not be transparent in your dealings. I think one of the things that we haven't learned as the medical profession is to learn to say, I do not know. We still act as if we know everything, and this is the impression that we give. And then when things go wrong, of course, we've got the resources, we've got our insurances that will provide lawyers that are a lot more adept at twisting things than the poor patient who will then come and then have to give evidence. Now, we know fully well that we've got very poor, low health literacy. So the patients will not be able to stand up there and talk against a specialist or a lawyer who is adept at that. So yes, people are starting to practice a lot more defensively. Yes, it does reduce access. We now know that there are fewer and fewer doctors who go into obstetrics to specialize in obstetrics for fear of the litigation. Currently, an obstetrician has to pay almost R1 million per year as the premium, as insurance for anything that goes wrong. We had a webinar just yesterday, and somebody who's working in the litigation, medical litigation, was actually sharing this with us. So yes, there'll be less and less obstetricians working because of the requirements. But those requirements are the basic things that we should be providing as a country. The fact that a woman in labor should have somebody who checks on her every 30 minutes, it's the norm. It's not going beyond the norm. But our health system currently does not even, promise anyone that every 15, 30 minutes, somebody will make sure that everything is going well. So yes and no, it does improve the quality. Unfortunately, the teaching aspect is also lacking because there are less and less teachers, specialists who are teaching in medical schools. Again, because of the material side, people are also doing private practice at a time when they should be in medical school. So the quality of those qualifications are now also becoming very questionable, and the supervision of the younger doctors. Yeah, I haven't answered the question, but I've just escalated it. Thank you.
Thank you for that. It certainly is very useful. There is a question in the chat, which I think is quite an important one, regarding informed consent, which we have spoken about quite a bit, and a very, very important issue and question in the context of medical malpractice. And this is from Kumisho Mogwerane, and they say that Prof. Mhlanga raised very important questions about patients' informed consent. My sense is that generally the public is often treated as disinterested, as not having the intellectual capacity to understand complexity, not only around biomedicine, but around all kinds of things, especially in a historical situation of thin literacy. Is the problem of informed consent not primarily a problem of an ultra-modern age that relies on experts and specialization in everything? Prof. Burns, do you have some thoughts on that?
I think it's an excellent comment, and it really goes to the heart of some of the things that that Eddie was talking about, and that Gilbani was about knowledge and power. On the one hand, we all probably have much more knowledge that can be brought to the surface. It's not that that any of us would pretend that Eddie is not an expert in obstetric and gynecology. He spent 7 or 8 years at university, followed by 10 years specializing, and has this enormous practice expertise combined with his continuous self-improvement and rigor. He belongs to scientific peer groups. He constantly analyzes his own practice. And in addition to that, as we can all see, somebody like Eddie brings passion, commitment, human rights to the table. If I was pregnant at the moment, or somebody that I loved was, I would say, let's try and get Dr. Eddie to be in the room that day. On the other hand, Eddie himself is telling us that ordinary people bring a lot of knowledge to their lives, and bringing that knowledge to the point of self-expression, self-responsibility, sharing that and being respected takes courage, it takes dignity, it takes mutual dialogical respect. In a society where people are disrespected or lose their own confidence about themselves, it's not only that the so-called ignorant person loses because they can't speak up in public, because they can't find the words that other people will understand for their own self-explanation. The medical practitioner loses too, because people like Eddie also lose their legitimacy. We end up with these fractious, litigious scenarios where somebody like Eddie has to pay R1 million a year to get insurance to be able to practice in Joburg or in a rural area. Nobody wins with that. So I think Kamisha is quite right. There is this complex field which we can all acknowledge. If somebody specializes for nearly 20 years in an area of knowledge like anthropology or art or legal practice or tax knowledge or care for small children or being a teacher, none of us would say that skill isn't worthwhile. On the other hand, we also have our own knowledge and integrity of our own bodies. We have to be able to find a respectful synapse, like the space between nerve endings, where we as people in the world connect with others who have bodies of knowledge in a mutually respectful, constitutive way. When we do that, medicine, biomedicine, works fantastically. When there's community buy-in, when people can be critical of medicine and medicine can be critical of itself, when medicine learns from ordinary men and women learn from medicine. This, however, is an ideal that doesn't happen often. And one of the reasons it falls down is medicine's own blindness or its sense of its own self-power. Another reason it falls down is what Kamisha's putting her finger on the pulse of, which is that people give up their autonomy from exhaustion, from shame, from a sense of a disinvestment. Their lack of autonomy and confidence reinscribes their sense of being other to themselves. And when we begin to lose that as a country, both sides lose. There's a dismal lack of legitimacy and trust in medicine, and medicine is not self-corrected by, held up, or legitimized by community involvement. And that is the wrong road for us to go. And when we see signs of that in society, look in this conversation how often we talked about women's bodies. I did bring men into the story, so did Kobani, and Eddie referred to the involvement of men as fathers and brothers too. But so often the discussion we have falls into the space of and the domain of reproductive health and sexuality and care for small children around vaccines. And this is because in our society, some of the people with the least autonomy and the least agency are nevertheless the people we rely upon the most. The whole country relies particularly upon the labor, the reproductive labor, the emotional labor, the physical sweated labor, particularly of Black women. And yet they are given very little space and often take up themselves very little space in these discussions. And so, you know, we're almost showing in our conversation today, we're almost exemplifying the points that people like Kunisha are bringing up in the discussion.
Thank you so much, Prof. Burns, for that very, very generous answer. I'm going, because I know that we will sit here until this evening. So I'm going to take another question from Rahel Nados. I hope I said that correctly. And they say, fantastic discussion. I wonder if the panelists can comment on what we need to change in formal medical education curriculum for healthcare providers to try to curb some of these downstream impacts. What skills and knowledge do we need to impart on our trainees that our current education system is failing to do? I wonder if there's anybody who feels particularly drawn to that question. Kobani, perhaps?
Sure. I think there's a lot. I don't think there's one approach. And I think the first one already, Prof. Mhlanga has already hinted at, which is really the absence of training. So I used to work a lot actually with medical students. And I think at the time, that was about 4 years ago, at the time, I think the statistic was something they have the equivalent in 5-6 years of training, they have the equivalent of only 1 semester of a social studies kind of course. So first of all, you have then these very brilliant medical practitioners, but who are really, first of all, not able to really engage issues outside of the biomedical because of the structure of their training. So I think that would be the first step, first of all, to really start to also train doctors to be able to engage issues that the issues that we've spoken about today. And you've seen a lot of how biomedicine has failed, particularly in terms of, for instance, particularly TB treatment. We've seen it with COVID. And a lot of this is often linked to various forms of communication, issues of over-medicalization. So really this idea that doctors themselves also don't have time. So as soon as you go, they give you 5 minutes and just pop pills, right? There's using that time that's actually taken to really understand the sources of ailment. So I think there's a number of things, training, addressing issues of bureaucracy. It's a huge issue, particularly tied to medical malpractice in South Africa, which is many people really dying, waiting, actually, to not even dying, accessing the help, but just the process of the structural of waiting for an ambulance, or being made to wait in long lines for hours before you are actually treated by a doctor. I think also, I mean, one of the things that I don't think I highlighted that I really wanted to really highlight is also to think about the ways in which biomedicine, particularly in African context, can actually work. There's this term that Richardson loves that he calls colonial amplification, which is really this idea of biomedicine really feeding into the purposeful development that was there under apartheid and colonialism, feeding into illicit financial flows and so on. So if we don't take into account all of these issues in a holistic form, I think we miss out. But I would say at the top of my mind, issues of the ways in which we train our doctors, structural barriers to accessing health, but also, as you were saying, Jamil, issues around proper lines of accountability. I think those would be the top 3, really people having access and being able to get justice in cases of medical malpractice. But I'll stop there for now.
One of the downsides of discussions this way is time, of course. And so we are nearing the end of the allocated time that we have provided for this discussion. And of course, I know that we would love for it to go on. And the more we talk about it and the more we share, the more we realize, oh, there's so many more questions to ask and there's so many more things to know. But with that said, I would like to bring us to the end of the discussion. And one of the little gifts that we promised for this discussion was to have some closing comments by one of our favorite medical practitioners, the UN Special Rapporteur on the right to health, Dr. Tlaleng Mofokeng. And I think we need to give Dr. Tlaleng just a few minutes to get online. But we are definitely looking forward to hearing those closing comments. And while that's happening, I just I thought about the comment that was made about the multiple, the multiple facets and thinking about healthcare not only in the context of reproductive health, but also thinking about how all of this links to multiple sectors of society. So with that last little nugget from me, I want to please invite Dr. Tlaleng Mofokeng to give some closing comments on the discussion that we've just had. Welcome, Dr. T.
Thank you so much, Jamil, and thank you to Professor Catherine Burns and to Professor Mhlanga and of course, Dr. Gambela. And just to say that if you guys think there's anything wrong with me, it is the fault of Professor Mhlanga and Catherine Burns because they both taught me at the University of KwaZulu-Natal. And in fact, the first time I fell in love with medical anthropology and the importance, right, of rooting the medical practice in a philosophy in justice was actually from Professor Catherine Burns' introductory lecture. And she got me really hooked up until I was a senior doctor, well, at least medical student, and I met Professor Mhlanga in the obstetric wards. And he taught me literally in a human figure what it is to be an ethical, caring, empathetic doctor. And I always said that if I succeed in life, I would have taken the teachings of Professor Catherine Burns in my own professional career, but also moduled in so many ways the way that Professor Mhlanga was a clinician. And of course, Dr. Gambela, we draw on your knowledge, we draw on your thought leadership, we draw on the importance of sociology, because often when we talk about health and the right to health, and especially now at the United Nations, where I'm working as the independent expert, often we talk about access to healthcare and services, but not enough about underlying determinants of health. And I think today we've done a really, really amazing job of firstly bringing the people who may be new to the space and giving them, different perspectives and ideas. But I also know, and I'm just taking directly from what Dr. Gambela said, that we speak a lot about things that happen on a grand scale. We must treat acts of malpractice that happen on a smaller scale like they do matter. And again, it's almost like you guys are threading with each other in some poetry. And Professor Burns says we must think about what's happening on our bodies, our sexuality, as fundamental and as important for what they are. Then we can discuss reproductive commodities. Not everything about us is about how we must be medicalized as human beings and women. And of course, Prof. Eddie, saying that of course we do tend to give the impression that we know everything as medical doctors, and we really don't. And that's the truth. And it's my wish and my vision that I bring to the UN role a very intentional move towards justice. Jamil spoke very well about gender justice, queer justice, and I'll even say land justice, environmental justice, economic justice, and how much being in good health, both physically and mentally, is important. But we have to talk about the roots and the remnants of colonialism and apartheid, and of course looking forward and being deliberately and intentionally intersectional in how we do our work. And so with that, without taking too much time, I would like to thank all of you for your continued support for the work that I'm doing at the UN. And please look out for my Human Rights Council report that's currently available online, and I'll be presenting that in an interactive dialogue in June, and again with the General Assembly in October. And thank you very much. I draw strength from all of you. And like I said, my mentors for decades now, it's almost like a dream come true to have all of you in this one call. And thank you very much as well to Jamil for being such an amazing moderator, and to all of our guests and attendees. Thank you very, very much.
Thank you, Dr. T. I can't think of a better way to end off this discussion. I would also just like to thank our panelists, Dr. Gambela, Prof. Burns, Prof. Eddie. Your contributions have been nothing short of enlightening and exciting. And I just want to thank you once again for the generosity with which you have approached participating today. For everybody that has tuned in, thank you very much for joining our very first webinar on a very important topic. This is but one in a series of webinars. So please do look out. We will be posting it on our Equity Twitter page, which is @OurEquity. Please, please, please do look out for that. And we welcome even conversations, suggestions around the very important work of advancing global health equity. And so until next time, thank you very much. Keep warm, keep safe, and have a wonderful weekend. Thank you very much.